All right, good morning. My name is John Delossantos of JMD Healthcare, and I'm here today to give you this great instructional webinar discussing our MDS assessment interviews. Some things that have become very important under this new payment model. We do a lot of audits, and we see that there's both some operational and some coding issues with these, and they've never been more important. So we felt like it was very important to bring this to other providers and make sure that we get these done right, okay? Now, before we get started, I just want to tell you a little bit more about JMD Healthcare. We are a skilled nursing facility management service. We offer the brand new RRAM service, which is a new oversight service that deals with both the MDS, ICD-10 coding, and therapy operations. Okay? Now we can either enhance your current programs, your contract therapy programs, whatever you got, or we may be able to replace it. We don't know yet. And, it takes some time to figure that out because we want to do what's best for you. And in some cases, contract therapy brings a lot of value and it's the best option. In other cases, it may not be. I don't know. And then also with PDPM, there's a bunch of opportunities for coding. This is a very complex algorithm and all of our staff are completely trained in it. So again, management experts in PDPM and therapy operations and integrating, bridging that gap between your therapy operations and your MDS, something that's never been around. If you want more information, 1-801-PDPM-PRO or hit us up on our website, pdpmpro.com. That's it. That's all I'm going to say about that. This isn't a commercial or anything. All right? So let's just get into this. Now the objectives for today are going to be, number one, to review the importance of this MDS assessment interviews. Not only how to do them or what they are named, we'll go over all four of them, obviously the intent and the rationale behind of it, but why it's also important for clinical aspects. Now we all know a few of these do feed into payment now, which is probably why they got the most attention, but there's other aspects that are important for care, okay? So we're gonna review all four of those, go over the intent and the rationale. We're going to go over how the assessment works and how it should be done, exactly how it should be done, step by step. There's a little bit of confusion about this. I have first-hand experience of that. And then we're going to review the coding instructions and then cover some examples. It's going to be really informative. I'm going to keep it moving as soon as possible. Keep it moving as fast as possible. If anybody knows anything about me, I don't like to waste a lot of time on stuff. If you did get this webinar, you will have access to it again whenever you want it. It's an on-demand service, so you can go back and check it. You can show it to your coworkers, your friends, your family, I don't care. As soon as I put it out there, it's for you to do whatever you think you need to do with it. All right? So I'm going to start with when. When did we start doing this? When we switched from MDS 2.0 to 3.0, they added this additional piece where facility staff would start to structure these interviews with assessments or residents to help them with their assessments. Okay, and I think that's a really good thing. Most of these residents do have the ability to kind of say how they feel, and you may actually be able to read more into that once you get with them. We have body language, we have the words they use, we have how they answer these questions. It's really good stuff, and I think it was important to do. And then why, on their side of it, this is out of the RAA manual, by the way, all residents are capable of any communication should be asked to provide information regarding what they consider the most important facets of their life. And that is important. It's not just getting the data. You also have to make sure that you're getting what the patients need. All right? And they say self-report is the single most reliable indicator of these topics. Staff should actively seek information from residents regarding specific topic areas. However, and this is what I was kind of hinting to earlier, however, resident interviews should become part of the supportive care environment that helps residents fulfill their choices over aspects of their lives. Wow. No, just kidding. No, but what that means is you're not just going in there and getting this data to help you fill in your blanks. You should be going in there to get an idea of what these patients need. Okay? That's how it starts. So let's go over these really quick. There's a few, like I mentioned earlier, there's a few that are related to payment. Okay, the first one is, and I know you're all familiar with these, but this is part of the process. Some of these people may not be as familiar, or some of you experienced MDS coordinators out there. But the BIMS, brief interview of medical status, is in section C, cognitive patterns, items C0, 100, and C0500. So this is something that's going to contribute to that payment under PDPM to the speech therapy component. And this isn't a PDPM in service, so I'm not gonna get into that. I love that, and I want to do it right now, so I'm trying to stop myself. But we'll, we can always have other ones, other webinars to kind of discuss that. Second one is the resident mood interview, the PHQ-9. All right, section D, mood, items D0100 to D0300, and there may be a few variances with qualifiers and some of the staff assessments, which we're not covering today. I'm not doing staff assessments, only doing the interviews, just so you know right off the bat. Also want to give you a little bit, I like giving a little, I don't know, trivia information. I like my webinars to be kind of informative, new stuff, not just going through the same old motions. So I was curious one day. I said, what's this PHQ-9? What's this -9 mean? And why does it have this copy mark thing? Why is it copyrighted? So I looked into that, and comes to find out the PHQ-9 is actually part of a much, much larger assessment called the Patient Health Questionnaire. And this is a self-report inventory used to screen mental disorders, okay? And it was developed by Pfizer, which is a pharmaceutical company, and they did copyright it, and they used this for their doctors in the 90s to help diagnose some of their patients' needs and make them appropriate for the level of medication they're receiving, okay? Now, where's the -9 come from? This is trivia. Maybe you guys have a facility trivia game, and this would be one of your questions. But the -9 actually comes from the number of questions on the original PHQ, Patient Health Questionnaire, the original PHQ that dealt with depression. 9 questions. And I think there was like 26 or 36, I can't remember. But there were so many, it was a long, long series of questions. But 9 of them dealt with depression, and they just put those 9 in the MDS, and that's why they call it the PHQ-9. There you go. You learned something today that wasn't just in the REI manual. Now, this contributes to the nursing PDPM components, to a few of them, and I'm going to go over that later also. But it will help with some of the reimbursement and multiple levels for your nursing components. All right? Then we have the non-payment related interviews. Okay? And not saying that these aren't important. We got to get off this idea that we only deal or are concerned about things that pay higher rates. We got to get off that. The non-payment related interviews are the interview of daily preferences, which as an OT is very important to me. I think it is important residents are recognized for what they feel like is home and what they feel like is a normal day, just like any of us would be. And that is in section F, preferences for customary routine and activities, F300 to F600. Although not related to payment, this is what it says on my spreadsheet here. Important to make residents feel comfortable and create an individualized plan for their stay. Very important. Now, this also is important on this is that it does contain some of the care area assessment triggers. So you're going to have to be using these for other items that are important, not just the PDPM side. Okay. Now, the next one is the pain assessment interview. And obviously, pain is an important topic always for our residents. We don't want our residents to be in pain. And it's a survey issue if you have residents in pain and you're not addressing it the right way. So this is always important. That is in section J, health conditions. J200 to J600, obviously important for care planning, pain management, also care area assessment and quality measure triggers. And quality measures, I'm just going to bust out and say this right now, are going to be very important in the very near future. With all that's happened with COVID, that 5-star rating is what people use to determine where they're going to send their loved ones. And if you do not have a good 5-star rating, which quality measures feeds into that, we're going to have a webinar about this very shortly. I would probably say within the next month or two. Been dealing with this a lot lately. If you do not have a good 5-star rating, people will not only, they won't even visit your facility, they won't even call your facility, you won't even know they even thought about your facility because everybody checks everyone else out on the internet now before they do anything. So it is very important that you get your 5-star rating to where it needs to be to make people comfortable coming to your facility because this market has just gotten more competitive than it even was before. So remember, quality measures, they're important. That's why this is going to be important for this interview. All right, so let's get right into them, not wasting any time. So the BIMs, the intent and the rationale. It's intended to determine the resident's attention, orientation, and ability to register and recall new information. Important stuff. A structured cognitive test is more accurate and reliable than observation alone. And I think all of you who have been in this field a long time, we get fooled sometimes by our residents about how confused they are. And it's not their fault. They're trying to deal with this the only way you really can. You know, you try to think that's not happening. And this is designed to help pull these things out. That's why it's very important you do these exactly how they're instructed, because there's a lot of thought that has got into this, and there's a lot of organization that went into this. And that's why these are so important, or you're going to get false returns and false information, and it's not going to help your residents. All right? Structured interviews will efficiently provide insight into the resident's current condition. Important. Pre-coding tips. And by the way, some of these pre-coding tips were the same for all of them, so just remember them. It applies to a lot of these will apply to all these interviews. You know, obviously, you attempt to conduct this interview with all your residents. You know, everyone should have a chance at this. And you know, and now today's days and age, we're talking about efficiency and staying busy. And if someone's unavailable and you think they're completely cognitively intact, I know nurses who have done this. I know MDS coordinators, even therapists who've done this. You guys, you can't do this for them, even if you think you know the answers. You just can't. It's not fair to them. You may not catch what you need to be catching. And you have to make sure that you try to do these with everyone you can, and not think filling these in for someone is going to be a good thing for anyone. It's not. It's really not. You're going to miscode something. Something's going to pop up you weren't aware of. And quite honestly, you shouldn't be filling them out anyway without not being around. That's not how you're supposed to do it. So please, it's very important. And this does happen, guys. I mean, I know some of you think, well, that's crazy. I would never do that. People do it. And they're not bad people. They're trying to speed up the process. Well, the process is the process. We need to do it. Okay? Interviews should be done in their preferred language. Hello, I mean, that makes sense. And if you can't get that, there's other ways you can try to deal with that, and we'll cover those later. If not conducted during the look-back period, you must code your patient as cognitively intact, no matter how confused they really are. That's why it's important you get these done in the time frame that is required, or they are considered intact. And that's going to cause a whole bunch of confusion in the future, and then it's all going to come back to people not getting their stuff done in time. And again, that goes back to why I was saying earlier, why people might try to do it. You got to get a better system in place. And I must say, you MDS coordinators out there, you have been very good in holding people accountable, so keep that up. It is the MDS coordinator's responsibility that these get done on time. And by the way, I put a next little bullet in there. You cannot do the staff assessment if you did not do this assessment and it was supposed to be done with the interview. You can't. It is not a safeguard. The staff assessment is strictly for those patients who cannot complete or cannot do this assessment. It is not for you to make up for your missed opportunities. If it should have been done, you need to find a way to get it done. Cue cards can assist for accuracy also. Back of the MDS, and I have some here, my cue cards that I was talking about earlier with somebody, cue cards here for pain and things like that. They're in the back of the REI manual. There's lots of other resources. ANAC has some resources. And if you do want a free set of these, contact JMD Healthcare, and we'll actually send you some of those too also, by the way. I think they're great. And actually, the REI manual talks about showing it to the patient and actually having them reading the words just to make sure you have them engaged. We'll talk about that later too. All right. So the steps for this assessment, okay? Start with the 200. The 100 was to decide if they do it or not. I think you can figure that one out. And the 200 will be the repetition of 3 words, okay? You conduct the interview in that private setting where the resident can hear you. Guys, I'm telling you, you better make sure your residents can hear you. And I think we all know the resident that's kind of leaning back, they got their eyes closed. Hey, you understand? Yeah, I'm here. This is important, and this is why sometimes bringing this card out to put in front of them to read it, or even look at it as you read it, get them to open their eyes to make sure that they're paying attention, they actually can hear you, because these answers are to be coded right when they say it, and you don't get a second chance. And there's a reason for that. I'm going to go over it. There's a reason why you don't get second chances on this. All right? Make sure they can hear you. Sit face to face, introduce yourself, make sure they know why you're there, make sure they know this is important, that all are the signs that this is an important thing. You understand that these residents, people coming in and out all day long, man, they don't know what you're doing. They hear the same stuff over and over. You got to make it clear this is an important thing. You need to be sitting up, you need to be looking at me, we need to face to face, you need to hear me, you need to know who I am and what I'm doing. It's important. You need to make that clear to that resident that this is an important assessment for them. So, you say to the resident, I'm going to say 3 words for you to remember. Please repeat the words after I say all 3. The words are sock, blue, and bed. Okay? And this is also a time you could have the cue card out, showing them socks, sock, blue, bed. Boom. There you go. They see it, they look at it, because what's important is immediately after saying those 3 words, this is your code. This is what you got to put. And if you didn't have your patient fully engaged, all right, and they weren't really aware of what you're saying, if they say, what were those words again? Or what are you doing again? Who are you? You lost it, man. You have to code it as 0. They got nothing. You can't do it any other way, because there's a process to this of how many times you can say these things from a medical perspective and what they've figured out about people's ability to retain information and how this assessment works. So you can't start over at this point. You've already messed it up. Sorry, I don't know. That's just the truth. I'm sorry. You already kind of did something that kind of blew it. Right? So you're going to have to code it to 0 if that works. So that's what my little thing is there. The response is what's to be recorded. Right there. That's it. No second chances. And I know the REI manual is a little bit confusing in this because it says you can repeat the words up to 2 to 3 times, but that has nothing to do with that first answer. This is what you code for the first answer. Okay? So after the resident's first attempt, to repeat the items, if correct, and this is important too, that's right. The words are sock, something to wear, blue, a color, and a bed, a piece of furniture. Okay? And there's a reason why you're doing it this way. There's a reason why you have to say those items and the, here we go, category cue that they're part of, because that's going to come up later. You can't just say, oh, good job, you got them all right. Yeah, the words were sock, blue, and bed. No, you see, again, you did the wrong thing. You got to make sure, even if they're right, you give them the category cue, because that is important to use later. Okay? Now, if the resident couldn't recall 2 or fewer words, you say to the resident, let me say those 3 words again. They are sock, something you wear, blue, a color, a bed, a piece of furniture. Now tell me the 3 words. Now this has nothing to do with what you're going to record though. You've already passed the point of what you record. This is the category cues that you're trying to give to them. And you can say that one more time if they get it wrong again, but that's it. You only get to say it 3 times. And it's not because you're trying to give them hints for this question. It's because there's a process to this and you cannot say them more than 3 times. Okay? If you have to go over that again, go ahead. I know that's kind of quick, but that is important. And this is one of the tougher ones. And people usually think, oh, the VIMS has been around for years, it's easy. No, it's not, because if you screw up these steps, you really get some inaccurate readings. All right. And then that's it. We'll be one more time. So we already talked about that. All right. Steps for coding CO 200, repetition of 3 words. Okay? The words may be recalled in any order, in any context. So if they even say some weirdo sentence, like, I wear blue socks when I lay in bed. They said sock in bed. So you can code it like that. All right? Do not score the number of repeated words on the 2nd or 3rd attempt. Okay, you're only going to sort it when they get it, they get it. You don't get a second one for the second time you say it. Okay? And the coding goes as follows. Code 0, if the resident can't say any of those words. You code 1, if they repeat 1 to 3. 2, I'm sorry, let me say that again. You code 1, if they get 1 of the 3 words. 2, if they say 2 of the 3 words. 3, if they get all 3. Okay? So, they can say them in any order, they can say them in any sentence, a little story, but they just got to say the words. Okay? Now, for 300, temporal orientation. We're going to get into some kind of their sense of what's going on right now. Ask the resident each of the following 3 questions separately. Please tell me what year it is right now, what month it is right now, and what day it is right now. All right? You allow up to 30 seconds for each of those answers without providing any cues. I mean, you can't give a clue or a cue or a category or nothing. You can't. Even if they ask you a question, you just got to say, hey, I need to know if you can answer these without me helping you at all. I'm sorry. It's just part of the process. If you don't know it, it's fine. It's just whatever you know is good enough. Leave it like that and let them answer the questions. People will probe you for questions, and you know it. You get questions left and right. All right? Now, for coding this, if they're able to record the correct year, there would be a 3, like correct, got it completely right. If they missed it by 1 year, it's 2, 2 to 5, 1. If they're off by 5 years or more, I'm sorry, you get a 0. So 5 years or more off, 0. Missed off by 2 to 5 years, you get a 1. Only by 1 year, get a 2. If you're in the correct year, you get that 3. All right. And then for B, the correct month, it's similar. You know, you get 0 for you missed it by 1 month or no answer. You get 1 if you miss it by 6 days to a month, and you're accurate within 5 days, which is kind of basically if you're accurate within the week of the month, it's you're good to go with that. All right. Now, a little tidbit here. The current day you're on is considered day 1. Okay, so it's actually 1 plus 4 more days. That's 5. People get confused on that. Well, was that tomorrow, yesterday? No, it's just today's 1. You got 4 days either way. Okay. And then 300C, able to report the correct day of the week. You either got to get the week, or you don't get any leeway on this one. You either get it right or you get it wrong, and that's it. Okay, 0 or 1. Steps for 400, the recall. Ask the resident the following thing. Let's go back to those. Now, this is what was important about that whole first stuff we were talking about in the BIMs. Let's go back to that earlier question. What are the 3 words that I asked you to repeat? And you allow up to 5 seconds for spontaneous recall of each of those words. 5 seconds apiece. You don't got to sit there all day. So if you're going by 15, 20 seconds, they only got 1, they're not going to get any more. But about 5 seconds apiece. For any word that is not correctly recalled after 5 seconds, you can provide one of those clues you gave earlier, the cues, the category cues or clues. They're kind of very close to the same word. That's why if they got this right and you forgot to give that little great congratulatory sentence about, hey, nice job, yes, sock, something you wear, blue, which is a color, bed, which is a piece of furniture. If you forgot to say that, they're never going to get this because you never said it. Okay, so that's why that was so important. All right, so that's why you got to remember to do that if even they get them right. You have up to 5 seconds after each category cueing for each missed word they recalled. All right, so they get the cue and they get 5 more seconds. Now, to code this, for each of the 3 words the resident is asked to remember, you code 0, could not recall. If the resident cannot recall the word even after been given the cue, or if they respond in a nonsensical answer, which we haven't talked about yet, and what that means of a nonsensical answer, and most people have heard this term or figured it out. If they give an answer that really has nothing to do with the topic, now if they say red, that's wrong. That's a color. They just didn't get the right one. If they say macaroni and cheese, yeah, that's the nonsensical answer. That really has nothing to do with what we're talking about. So the nonsensical answer comes into play when the answer they're given doesn't even fit the conversation that you're having at all. It's just way off the wall. That's a nonsensical answer. And we got a little more examples of those in the future. You code 1, yes, after queuing, if the resident requires the category cue, and all of a sudden remembers the word. Cool. A color. Blue, that's right, blue. Cool, that's cool. Or you code 2. No cue required. They can get them right off the bat. And believe it or not, there's some people that are pretty good at that. So I'm not sure if I would be good at that the first time I had to do it. especially when you're in a new environment, you're in a nursing home, you're going to be stuck there for a while. Some people are really good at this, kind of surprise you. So let's go back to that nonsensical, all right? Incomprehensible, unrelated, or incoherent. Again, if you're give them a cue for one of the words and it's a color and they tell you macaroni and cheese, no, nonsensical answer. Doesn't make sense. Doesn't fit anything. If they said red, yeah, that makes sense. Or if they said plaid, that still makes sense. It's still within the realm of possibility that, yeah, some people think that's kind of a color. You get a plaid shirt, plaid pants, somebody wears those. But, I could see that. But if macaroni and cheese, hamburger, something like that, no, can't give them credit. Okay, coding tips. If on the first try, without cueing, the resident names multiple items in a category, one of which is correct, code them for that item. So what that means is that first question comes up for the recall, and they say, red, yellow, blue, orange. Red, yellow, blue, orange. They still get credit for that because they're kind of working out the process in their head, and they did get the color. Some people will code that as not being right because they gave all these separate answers, and they're kind of guessing at it. For the first attempt, that is okay. For the later ones, it won't be. But for the first one, that is okay. If the interviewer gives a resident a cue, and the resident then names multiple items in that category, the item is to be coded could not recall. Okay, because now they know it is a color, and now they can start working through every single color they have in their head. With the first question, you really didn't give them that cue yet of color, but they knew it was something about color, so they get credit for that. So that's the logic behind that, and that's how they want us to code it. And that's confusing to some people. And it goes so fast, and sometimes you let these questions start gliding in, and then you start questioning yourself, did I say that right? So that's why you have to have a process down. You got to go through the process. That's why cue cards are such a good idea, because that will keep you on task. And if you don't deviate from what's on the cue cards, you'll always know you give a good, accurate assessment. All right. Now, to score the C500, you add up, and this is the total score, you add up the values of all the questions, 200 to 400. You total the score with a 2-digit number, which could be 00 to 15. If the resident chooses not to answer a specific question, code is incorrect and count it in the total score. However, if the resident chooses not to answer 4 or more interview questions, it's coded as incomplete. So 4 is the magic number. If they do not get 4, if they refuse to answer or will not answer, refuse to answer 4 of these questions, you cannot count it as an assessment. And I've seen people try to do this. I've seen people, we actually do competency checks for our coding for our interviews. And I've seen people just put them wrong for like 5 in a row. I'm like, you let them complete it because it's good practice, but then you have to tell them after, you know what, you can't even count that assessment anymore. If they get 4, they don't answer, or 4 that are nonsensical, or 4 that they were just refuse, or they're getting agitated and they're really just saying, I don't know, man, I don't know. You kind of lost it. You can't do more than 4. Now, the resident must attempt to provide relative answers for at least 4 of those questions. Okay? Code 99 if the resident chooses not to participate, or if 4 or more of those questions were coded to 0 because they choose not to answer or give that nonsensical response. And sometimes people will start doing this when they start to feel like they're not doing well, and you want to make sure that they do try to encourage them, and before they get really agitated. And when they start getting agitated, you'll start to see people not want to do this anymore. And one of the ways of showing they don't want to do this anymore is starting to give nonsensical answers. And you really want to try to reel them back in and tell them this is important. We want it's okay. Okay, sometimes you got to say it's okay if you don't remember these. No one's grading you on that ability. We're grading you to make sure that we give you what you need. And if there's certain things we need to work on, we can work on them with you. This is something that's going to try to help you, and that's a hard thing, and I think it'd be hard for any of us. But you need to try to reel them in So they don't get too frustrated, and you get a lot of interviews that you can't count. All right, now you dash any items that are not asked, and then you code 99 for the assessment. Just it's a scenario I'm given. If they give up and quit, you don't even get to them. You go ahead and dash them, then 99 would be the final score. All right, planning and impact. The BIMS is a brief screener that aids in the detection of cognitive impairment. It does not assess all the possible aspects of cognitive impairment, though. It doesn't assess everything. It's not a diagnosis. It's just a tool to see where someone is kind of at so we know how to take care of them, okay? Results indicate 13 to 15, you're cognitively intact. And that's a pretty good score to get that much. 8 to 12, moderately impaired. 0 to 7, you're going to be severely impaired. Financial aspect or financial impact. This adds the cognitive impairment to the speech therapy component, which is one of the components that get added up with comorbidities and swallowing diagnosis to give it a different HIPS code, a different CMG code, which goes to a HIPS code and will increase reimbursement. Now, we're not seeking anything out to get more reimbursement, but the idea is the patients that do need more care due to cognitive impairments enables your facility to be reimbursed for that. That's where that's going to come from. All right, and that can increase your range $13 to $21 per day, per patient, every day, if you capture some of these components. So that's why this is really important to you, to make sure you get the reimbursement you deserve for the patients you have. All right, so anyone into that cognitively impaired category or higher or less, however you want to look at it, will contribute to that. Okay, and it really doesn't go with severity. It's if they're cognitively impaired, yes or no, kind of an idea, and that's what adds to it. So you're not trying to push for severe impairment or anything, but if someone is cognitively impaired, they obviously require a little more care. Now this also triggers your care assessment areas and your quality measures for long stay. So important thing too, which quality measure I already touched on. All right, now next one, PHQ-9. Resident mood interview. Rationale and intent. The items in this section address mood distress and serious condition that is underdiagnosed and undertreated in the nursing home and is associated with significant morbidity. I wrote is with an underline because that literally how it's written in the RAA manual. That's how important whoever put these things together thinks this is. And they didn't say may, they didn't say could, they said is undiagnosed, is associated with significant morbidity. Morbidity. So they definitely believe in this test. And that's why I did that, just for that purpose, to stress that directly from the RAI. Depression is associated with physiological and physical stress, decreased participation in therapy activities. We all felt that as therapists. Decreased functional status and poorer outcomes. It's like if you're not into it, it doesn't help you as much. If you're having this negative connotation about your demeanor and how you think your day is, sometimes those things are very hard to do. I think we've all kind of felt that. Well, it's multiplied by 100 when you're in a nursing home. So we want to detect this and we'll make sure it's addressed. Findings suggest mood distress should lead to identifying causes and contributing factors, identifying interventions, and ensuring resident safety. So these results will lead us to make better decisions on those three things. And that's true. It is. Now notice, in the manual and in all the instructions I've seen, they don't say suggesting mood distress gets you more money. That's not the intent of any of these. The new PDPM payment model, I believe, is more appropriate for the skilled nursing facility because it's based on the patient's needs. But there is no more important thing than another on that MDS just because it gets you more money. Everything needs to be addressed the same way. They just couldn't put something on every single piece. I mean, that would just imagine what kind of an audit nightmare that would be. They take long enough under PDPM, trust me. But to do every single piece, it's just unrealistic. So they had to pick certain things that they felt were more important and that's why they did it. But it does not mean those other items are not important. I just wanted to say that. All right. So, steps for the assessment under this one. If the patient is rarely or never understood in any method, you skip to D0500 and put 0 for that staff assessment. If they can't participate in this and they can't give relevant answers, you're going to have to go about it another way, and we're not covering that. We're just covering the interviews. If the resident does or is usually understood by any method, writing, picture, pointing, speaking, you go to 200, which is the start of the interview, and you code 1 in that first 100. Okay, now explain the reason for the interview before beginning. The suggested language, and again, this is suggested. This is an actual part of the assessment. This is a suggestion. I'm going to ask you some questions about your mood or your feelings over the last 2 weeks. I will also ask some common problems that are known to go along with feeling down. Some of the questions may seem personal, but everyone is asked to answer them. This will help us provide you with better care. And I think that's I couldn't even add anything better than that. It's simple, it's to the point. It's, you don't need to be feeling sorry for people at this point. You need to be honest, transparent about what you're looking for. They know they're there for treatment in multiple areas. They already know that. At least tell them what you're looking for. Hey, if you're feeling down, maybe we can help you with this. All right? So that's a good suggestion on what to say. That's a good start. Explain and or show, again, cards, the interview response choices, suggested language. I'm going to ask you how often you have been bothered by some particular problem over the last 2 weeks. I will give you the choices that you see on this card while pointing at them. Again, very good idea. I'm telling you guys, this will make sure your resident is engaged in what you're doing. They know the importance, that they're listening, they're seeing. They're going to give you better answers if you do this. Get some cue cards, man. They're not hard to get. You can print it, laminate it. You don't even have to laminate it. You just cut it out, carry it in your pocket. It's a really, really good idea. I'm just telling you. And hey, if you need them, I'll send them to you. I will give you the choices you see on this card. 0 to 1 days, which is basically never. 2 to 6 days, which is several days. 7 to 11 days, which is more than half the days. Or 12 to 14 days nearly every day. And this is what I tell everyone about this interview. 2 weeks is a long time, okay? If you sat right now and you sat and thought about what have I done over the last 2 weeks. I mean, there's sometimes I'm like, it's already Thursday, and I'm thinking Monday was way long in the past, so you need to stress that a little bit before you start, so people are aware of that. These people, their whole ordeal of falling, hospital, surgery, in the home, it could be under 2 weeks. That's the whole thing. Sometimes when people say these things so fast and they do these interviews, I can tell the patient is thinking maybe of yesterday, maybe the day before. They're not thinking 2 weeks ago. They're not. So you need to make sure that they are clear on the idea this is 2 weeks, 14 days, a long time. Okay? Maybe give them a reference, like, by the way, you fell, before 14 days ago. Just I want to give you some perspective of how to think about this. It's important because I think we get some coded stuff because residents, they're not thinking that far out. And it's something that takes a little effort to do. Okay? Then, I kind of cut this out for us so we don't have to go through every single word of these questions. But you would just go read through each as written, little interest and pleasure doing things, feeling down and depressed and hopeless, go through every single one of them. And then we're going to look at the presence and the frequency. All right? These are pretty simple to explain. The only one that's a little tricky is going to be that last one. Thoughts that you were better off dead, or you wanted to hurt yourself in some way. That's a difficult question to answer and to ask sometimes. And the best way to do it is just like one of the other questions. Say it right in the same order, right with the same cadence. Don't say, okay, now this is a big one, and I don't want you to freak out or anything. I don't want to make you feel bad. Don't do that. That really builds people up, builds up their anxiety. You're already going through all these questions. They don't like answering them. It's just one of the questions, you know? And if they say, no, of course not. Well, okay, it's on my sheet, man. I'm just reading my page, you know? But at least you can just make it a little less. And maybe someone will say, yeah, you know, I have. And in that case, you do need to let somebody know immediately. And you probably shouldn't leave that person alone until you get someone else in or talk to that person, because, you know, that's a serious concern. And it's a serious thing to have to deal with as a caregiver and as a resident. That's a serious concern. But if you say it right along with your regular questions, it won't build it up and make some dramatic thing, or people won't be hesitant to answer it at all. And you can get some honesty. And people will appreciate that if, you know, you're willing to listen. All right? Okay. Do not provide definitions, because the meaning must be based on the resident's interpretation. This is parts of the assessment. You don't want to tell them what bad is. You don't want to tell them what feeling down means. It's up to them. These are very simple terms, and if you coded them to be able to do this assessment, they should be able to answer these questions based on how they're written. Don't give them interpretations, because you may change their answers. All right? They may be looking for that too, by the way. They'll probe you for some guidance on how to answer these. Each question must be asked in sequence to assess presence, column 1, if that is there, and frequency, column 2, how often, before you go to the next question. And I've seen people do this, and I know people say, oh, that's crazy. They went through all, okay, do any of these things happen? Blah, 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 blah. Okay, and if they did, how many times? Blah, 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 blah. No, it's one at a time. You get both answers. And there's a reason people answer differently when you do it this way. Enter a code for any response that's unrelated, incomprehensible, incoherent, a nonsensical response. We've already covered this. So if they say, you know, have you felt down lately, macaroni and cheese? No, it doesn't make any sense. You don't feel like macaroni and cheese. So, and if you do, we have other issues. But anyway, you need to make sure that they're listening, that they're engaged, that they're understanding what you're saying, or this isn't worth much. For a yes response, ask the resident to tell you how often he or she is bothered with the symptom over 14 days. Okay? Sometimes I like to stress that. And again, the coding is 0, 1, almost never, 1, never, or almost never will be considered 0 to 1. 2 to 6 days is several. 7 to 11, half or more. And then obviously 12 to 14, that's nearly every day. Okay, so steps for how to actually code this. The presence and the frequency have their own answers. Okay, you gotta and don't butt them up to each other either. So when I say this question, just tell me if it happens and how much. You really got to take your time with this. Sometimes if you try to rush them through it, they're not going to give you honest answers. So again, if you're going to go into the symptom presence, it's just it's there or not. So in column 1, you're going to put 0 for a no. It's just not present at all. Then 1 for a yes, if the resident gives you that the symptoms are present. And then a 9 for the non-response or the nonsensical. That's the first column. On the second column would be the frequency. So if they say yes for the symptom, you go ahead and ask for the frequency. Right in order of the questions, not come back to the ones that they said yes to. In order, all right? So the frequency would go, like we said before, never to 1 day, 0, 2 to 6 days, 1, 7 to 11 days, 2, 12 to 14 would be your almost every day, 3, all right? Okay. Select only one frequency response per item. If they get confused, if they get into a difficult situation where they're saying, well, maybe it is several, or no, maybe it's just, you got to go with the higher one. You always go with the higher one. If they're leaning in that direction, it probably is more in that direction, and it may be even worse than what they're saying. So always pick the higher one. Residents may respond verbally or with cue cards or in writing. Again, sometimes it's easier, guys, if you have these cards in front of them and they can point. Sometimes it's easier for people to do that than say it. So I always would suggest using these cue cards. Repeat the question if you think it was misunderstood or misinterpreted. You know, this isn't like the BIMS where you're trying to recall things. You're trying to get real answers here, so you can repeat it. Even twice, I guess. You know, don't get lost in the weeds with going over each question again and again and again. But it's okay to say them a couple times. Responses like, well, not really. I don't know. Sometimes. Well, you know, not that much. Maybe not. You need to explore that a little bit just to make sure you get a number. You need to get a number, and that's when the cue cards come in well too. Okay, so you said sometimes. Would it be sometimes 1 or 0, or sometimes 7 to 11? You know, you can point that out, and that may be easier for them to answer that way. All right? Narrow down the answer to response choices available. They can be useful to summarize their longer answers, and then ask them which best applies. Sometimes they're going to give you a long, drug-out, paragraph-long answer, and you can sum it. So what you're saying is it happens about once or twice a week. So over those last 14 days, maybe 3 or 4 times, you can do that. That's fine. You're going to just do the math for them sometimes. Sometimes they think it out really good. They talk it out instead of think it out, and you got to reel them in and get the honest answer. So coding this, again, we covered this, but let's do it one more time. Now you're going to add up the frequencies, which is going to actually give you your answer, and that maximum score is 27. The presence is just going to lead you to get the frequencies. So you really don't use those numbers. You're going to use the frequencies, okay? If symptom frequency is blank for 3 or more items, the review is deemed not complete. So with the BIMS, it's 4. With the PHQ-9, it's 3. If you can't get 3 of these to be completed, either refused, nonsensical, got frustrated, and started giving you, you can just tell they're not honest answers. You know, they're rushing through it. They're not into it anymore. And you can't really code it. They won't even give you a number because they get frustrated. You can only get 3 of those before you have to say, no, can't do it. Do it to staff assessment, which we're not covering, by the way, again. But the staff assessment will be a whole different thing. But if you're not going to get honest answers, you got to find it some way. And the total severity score is interpreted as follows. So 1 to 4, and again, this is only the frequency. I'm going to stress that again. 1 to 4 would be minimal depression, 5 to 9, mild, 10 to 14, moderate, 15 to 19, moderately severe, and then 20 to 27, severe. 27, I've never had somebody get a 27. That would be a lot of stuff going on. And when these assessments, honestly, historically, have been very low. I do think there's a few flaws in this system with the elderly and with people that are slightly cognitively impaired. Like I was talking about earlier, the 14-day, I call it think back period, is hard for some of them to visualize. I also feel like some of these residents are already in a very low energy mood, and they don't really want to talk about this, and they don't want to admit to how many times they feel this way. So we get a lot of low. I mean, honestly, I have some facilities that get 0 every single time. And we have to really do some training to make sure that they understand this, because it can't be 0 every time, man. I'm sorry, it can't. I mean, I would get probably a 10 on some of this some days. So to get 0s with everyone they do this with that's coming into a nursing home that's just had a big event and with COVID going on, I don't know, man. I think we have to take a little more time with some of these to make sure we get more accurate answers, because that just doesn't seem right to me. All right, so we really want to stress that, and even though some people don't like to get depression on their quality measure reports because it kind of goes against you if you're outside of the percentage, it's a real thing that needs to be addressed, and that cannot be an incentive. You need to get real answers for people, and it's important for the families to know, important for the residents, important for the doctors to treat them. And, when they're not participating in therapy and everyone's trying to figure out why, and therapists are saying over and over, they won't get up, they don't want to do anything, they're unmotivated, they say they really, they're giving up, and they have a 0 on their MDS, it doesn't make a whole lot of sense. So a little more effort in these may reveal a few more needs, okay? Now, in order for this to contribute, like I said, they contribute towards the nursing levels. In order for this to contribute towards the nursing levels, it does at least have to be a 10. And again, it's kind of an all or nothing situation, just like it was for the BIMs. So if they have 1 to 9, they wouldn't qualify. If they're 10 or above, not that that's something you're shooting for every time, but if it's 10 or above, then they would. That's just how it falls, and that's just how the algorithm works. Again, this isn't a PDPM webinar, but I think it's just good to understand that. Now, in order to kind of show that impact, I put this little graph together. It came out kind of cool, like the colors. So if you have someone in special care high, and they have the GG score of 0 to 5, and their payment per day, I can't remember what region this was. I'm sorry. I think it's Ohio or something. I don't know. But that's irrelevant because it's going to be the increases that are important. And you get that depression score with that, you're looking at $36 a day because that person needs some attention. You know, they're going to need somebody more involved with their care, and that takes more hours out of your day to do that. So that's a very fair situation, I believe. It gives you, and don't get me wrong, this isn't just about the money. To get the extra dollars your facilities deserve, right, that would enable you to take care of your residents better. You know, if you have 10 patients that are depressed, they need some extra attention, and getting those extra dollars is what that's for. So you can use your staff hours and still bring in enough to cover those staff hours to make sure those people are taken care of. So this is worth getting. It's important. So that's kind of where it goes. So you're looking at a 14 to 17% increase on your nursing CMGs by capturing this depression when people have it. You know, and that's a good thing for the facility and the residents in the long run, because you have the ability to give them more attention. And that's how it works. That makes sense. Okay, now we're going to the unpaid, the next ones, which are still important. And like I said, I'm an OT, man. This is important stuff. Personally, we try to train therapists to do this because this actually should be incorporated into their treatment plans for their residents for therapy. I think this should be right in there, man. Some of these things that they want to do, you know, you may be working on goals for therapy that's for stuff they're not even interested in. You know, you're not going to do good at it if they're interested in it. All right, give them stuff they're interested in. This would give you that opportunity. But contract therapists are good at a lot of things. I can tell you this: coding MDS is not one of them. So if you are going to do this, make sure you have somebody help train them in this coding, so the facility gets everything they also deserve, making sure they're coded right. Okay, and if you need help with that, feel free to call our office, and we can give you some good training ideas, or a service that will help you train people to be able to do this effectively, efficiently, and appropriately. Anyway, so the intent and rationale behind this. The intent of this section is to obtain information regarding the residents' preferences of daily activities. Hello, that's the OT right there. And information obtained directly for the resident or the family, significant other, or staff interviews. I mean, this is from anybody, really. You know, this is sometimes the residents are not all forthcoming, or they're a little crabby, or they might be asleep. If their family members there, no problem. Talk to them and see what they think. Hearing the resident's voice is the most reliable. We talked about that. Quality of life is greatly enhanced when care respects the resident's choice regarding anything that is important to that resident. And see, there it is right there. You know, if you're in therapy doing stuff that they don't even do, they're not going to do it, and they're not going to think it's good for them. If you get their interest and you do something that's important to them, this is really going to help. Okay? You know, some people don't care about the clothes they wear. I would wear the same clothes every day. It wouldn't bother me. I really wouldn't. There are other people that would not work. They like to be dressed a certain way on certain days, doing certain things, and that's important to them, and it needs to be identified, and it needs to be recognized. And that's exactly what this assessment is for. Interviews a lot of residents' voice to be reflected in that care plan. There it is. All right, and I took a snip of this just so it got a little bit easier. And these assessment questions are again, very simple, understandable. How important are clothes you wear? How important is it for you to take care of your belongings or things? How important to choose a bathtub shower? Those choices, snacks, your own bedtime, all those things. You just go through all these questions and kind of get that information from them. And quite honestly, this is one of those assessments that actually sparks a little bit of good in the situation. I think they like being heard. to hear this. They like that someone's taking the interest. And let me just touch on this, and I know I get off topic a little bit, but I think of all these good things that pop in my head. Take really genuine interest when you're talking to your residents when you do this. Don't do it like a checkoff sheet, like you're at a grocery store and you're checking off how many pieces of fruit, are on the stand, how many are bad, next, check, next, check. No, listen to what they're saying to you. Ask them a couple questions. Compliment on them, telling you this information, telling you you're going to help them with that. Take interest in what you're doing with these people when they're answering these questions. I mean, I see people rifle through this like it's a chore, it's just something that they have to do. They don't even want to do it. It's not a good impression you want to give. And our direct care is what gives us the representation of how we do care, is the direct care. So that's really where it happens, right there. That's customer service. Patient to caregiver, direct care, these types of things, it defines your buildings. Make sure people are taking interest when they do these. All right, steps for this assessment. Sit that resident face to face. We talked about that. Make sure they can hear you. And then, another suggestion for a beginning, I'd like to ask you a few questions about your daily routines. The reason is that the staff here would like to know what's important to you. This helps us plan your care and helps you be more comfortable. Even if you're only going to be here for a few days, we want to make sure your stay is as comfortable as possible. And trust me, I know why they added that in there, because you get through half that statement and they're going to say, I'm not staying here long. My doctor said I'm leaving on Monday, by the way. Okay, I'm just saying, even till Monday, we just want to make sure you're comfortable till Monday. You should be comfortable every day. So that's a really good suggestion to start this interview. Explain the interview responses, choices. While explaining, also show the resident, again, cue cards. It will make it a little bit easier. Explain. Explain the important but can't be do your choice exhaustion. Okay, this is something that is confusing to both residents and interviewers. Important but can't do it, or no choice. Explain why that's relevant, what that means, and that you are, again, genuinely interested in getting them to do everything they want to do, but some things just aren't possible, but we will try. There are a lot of things when people coming to these facilities that they used to do that they just can't do anymore. And then that makes this a depressive thing again. So explain why that's important. Explain why you want to know that. Explain that those are things that maybe possibly you could work. Again, therapy, great place to get some goals for someone and make them show they were heard. Could you imagine if you're doing this interview with someone and they said, yeah, I really liked to bowl, but I can't anymore, but I really did love doing that, and they get into this conversation about getting depressed. I mean, how excited would they be if your OTs or your PTs set up some balance activities where incorporated some type of bowling activity into that? That would make this person's day, make their stay. That's what I say, make their stay, don't make their day, because it's more than a day sometimes, most of the time. So make their stay by having the ability to do these things. And guess what? That's a really, really effective way to treat someone's balance, by the way. A bowling simulation for someone who's having balance issues is a great activity that gets their mind off of watching their balance and engage in what they're doing in multiple things, both sensory, their vision, their proprioception, muscular, muscle planning, muscle memory. Great thing to do. And if they're interested in that, man, that is a perfect opportunity to incorporate that in your treatment. I mean, that's why this stuff is so important. All right, so explain that to them. And again, residents may respond verbally, cue cards, or writing the answer. Now, if a resident cannot record preferences, you can interview with family, significant others, friends. Sometimes you can find some stuff in the chart, what they used to do. Code each of the questions with the following. 1, very important. 2, somewhat important. 3, not very important. 4, not important at all. And then 5, the one we just talked about, important, but I can't do it or have no choice. Because that's when you need to probe a little bit more. And sometimes not important at all. When you can kind of tell it is a little bit, it's worth bringing it up just for a second. And then our good old friend number 9, that goes to our people who don't want to answer. This is a longer one, so people may get a little frustrated with it. Try to redirect them a little bit. Say, look, we ask everyone the same questions. We just don't want to miss anything. That's right. And then the nonsensical answers. What do you like to wear? Your clothes and stuff. And they're talking about going swimming or something that really doesn't have anything to do with what we're talking about. I'm sure you'll figure those out, and you can usually see those really quick. All right, so steps for coding, section F, daily preferences. These are the tips and techniques. Interview is incomplete if the resident gives nonsensical or fails to respond to 3 or more of the 16. That's a pretty low amount, gotta tell you. If someone starts losing interest in this, I could see you adding up 3 non-responses really quick. So make it a little interesting, make it a little funner than what you really, just the monotony of reading it like a robot. Are you going to lose people on this one? I'm telling you. 16 questions, that's a lot, especially if they're not into answering any of them. They're having a bad day. It could go south quick. So there's only 3 of those and you're done. For an incomplete, you fill out a 9 and then you proceed to the daily activity preferences primary respondent, and we're going to cover that in a minute. Now, there's no look-back period for this resident, all right? But the current preferences are while they're going to be in the nursing home. That's a little confusing because a lot of these things are kind of choices, but the choices are going to be relevant to their stay at the nursing home. If they say, well, I like to hang my clothes outside to dry. Well, probably not doing that here, sorry. So there is no look back for how long they have these preferences, but these are concerning the activities and the things they will be engaging in while on their stay. But the facility, you're still doing a 7-day look back for getting these done. Okay, to narrow the answer or response, it's useful to use echo, which is a longer answer, and then you give a question and reply. So what that means is you're going to repeat back to them and kind of summarize for what they say and get the yay or nay to make sure that you got it right. You kind of echo what they said, but you sum it up. And it's pretty effective, and most people do it anyway. It's kind of a normal piece of conversation where you're trying to get information, but that's just what they term it. All right, steps for coding, section F. This is the section F, 600, daily and activity preferences, primary respondent. This is just a quick little question, I guess, that establishes the source, all right? So you would either put the resident was the primary source, a family member, or the interview couldn't be completed. That's just part of the question. It's just so they know this did not maybe come from the resident directly. It came from the family member, so maybe a little off. Or, hey, this is what the resident said to me, their own words. It's just what they put on there. It doesn't have none of these have anything to do with the PDPM payment, but both of these have the care assessment area triggers for your care assessments. And it has to do with making their own choices, So that's why that question comes to be so important, because the resident was the primary source. And so that's kind of why that's there. All right. One more. We're almost there. Hang in there. This is good stuff. You could always go back and, again, review this and go over it again. I'm going through a lot of stuff, but I don't want to take everyone's entire day doing this. Give you at least where you have the questions. You can go back and figure it out on your own, the rest of it. But I think this is the major pitfalls we're covering, I think. All right, so health assessments, J300, J600, intent and rationale for this. Obviously, pain's no good. Pain will cause suffering. It's associated with inactivity, social withdrawal, depression, whole bunch of bad stuff. Financial decline. Most residents with moderate severe pain require regular PRN pain medication. Some will require a regular dose of pain medication and PRN medication. So they're on a routine dose already. They're getting, a Vicodin every day at lunch because their back pain is so bad. And additional pain on top of that with extra activity. So a lot of these residents have pain as a major part of their life now, unfortunately. That's just how it is, when you get older. Pain can influence their participation in rehab. I can tell you that right now. I mean, everyone's in pain when they come and treat, when I come and treat them. But if it becomes a barrier, I mean, we've had some state survey issues come up where the reporting of pain has been a little lacking, and the state felt like we impeded their ability to show more progress because we didn't appropriately manage that pain. That's a real thing. And even though this has nothing to do with payment, it will if you start getting nailed with fines because you're not handling this correctly and you're not knowing what you're getting into. Sometimes you even realize just by doing this assessment, Mr. So-and-so is going to have to get some PRN meds before they go to therapy, for sure. It needs to be charted, it needs to be care planned, and the therapist needs to know, or they're not going to do anything, okay? Effective pain management interventions can help avoid the adverse outcomes, which obviously inactivity. People that are in severe pain and then they have like something come up, like a hip replacement, they already have back troubles. Man, they may never get up again, man. That's sad. Somebody falls and breaks a hip and they already have bad back pain. They've been in bed for a week and a half. You better get out of it. You don't have much time left, or they're not going to be walking anymore, unfortunately. So the pain medication is a way to break past some of these barriers and enable them to at least get the motion started and move in the right direction. There's definitely a place for pain management. Goals of pain management for most residents would be to achieve a constant level of comfort while maintaining as function as possible. Hey, that's exactly what I was just saying, man. I wasn't even planning that. That just happened. Exactly what I was just saying. You want them to be comfortable, but you want them to be functional. You don't want to over-medicate them, but you want them to be able to participate. It's a balance, man. If you don't do these assessments right, you're out of balance. People are not going to get better. So that's why these are so important. All right, so the steps for this assessment, this is an easy one, it goes quick. The medical record, it is always good to look at the medical record and know what their current routine is or the regimen of pain meds if they get it every day. It's good to know that when you go in. It's good to know kind of what you're starting with. So you want to review that, talk to caregivers if there's any interventions going out right now. You want to conduct the interview in a private setting, like we've mentioned earlier. A good introduction would be, I'd like to ask you some questions about pain. The reason I'm asking these questions is I understand how often you have pain, how severe it is, and how pain affects your daily activities. This will help me develop the best plan of care for your pain. That's why you need to know. I mean, don't say that if you didn't look at it. All right? I mean, I wouldn't appreciate that. If you come in here and you're reading something off a cue card or reading something to me, and then, well, do you know what pain meds I get? No, I really don't know. I'm like, what are you doing, man? So be prepared. Look at, have an idea of what, it only takes a minute, man. It's not a big deal. But at least know a little about that patient, know what their pain regimen is, know their history a little bit about pain, and have a serious conversation about it. You're going to discredit kind of what you're kind of doing when you walk in there and you really don't know. So that has a little bit more importance than what people initially think. The pain assessment interview of residents consists of a primary question and 3 follow-ups. All right? And there they are, right there. Pretty simple. So you have the primary, which is the presence, okay? And then the follow-up, kind of like we did with the PHQ-9. Do you have the symptom or do you have the situation, occurrence? And then how many times does it happen? So, you're asking the residents, have the pain in the last 5 days? And how much experience has been hurting over the last 5 days, trouble sleeping, day-to-day activities, and those would be the follow-up questions in reference to that pain. And basically, it's telling you how much it's affecting their life, okay? Primary questions, 3 follow-ups. So, as a resident, have you had pain or hurting at any time in the last 5 days? You're going to get a whole slew of pain issues with some residents, and they'll love to tell you all about them, okay? And again, take some interest, listen to what they have to say. It may seem like taking a little extra time, but I think it's important for them to be heard, So we call the presence or absence of pain regardless of the pain management efforts. All right, so you can't say, well, I don't know about that, man. You get a Vicodin every afternoon. I just can't believe you're still having pain. That's not what this is about. This isn't a judgment if it's effective or not. Know the history of their pain management and you're asking them the questions. That's it. You're not analyzing anything yet. This is a piece of the puzzle for you and others on your team to analyze that later. You don't do it during this interview. I've seen people try this, and it's not cool. So you'll code 0, no. If they say no, no pain. And then you can skip right to the shortness of breath, which is the next thing in this section J. Because that means there's nothing else to answer. There's nothing to ask. If it's not there, there's no follow-up questions. Now, the code 1, you got to do the follow-ups. So you go to the next one, which would be 400. And again, good old friend, number 9, if they refuse to answer, unable to answer, or they're giving you some nonsensical information, you're going to have to go over the staff assessment. And there's ways to figure that out too. Again, that's not part of this in-service. Ask the resident, how much pain have you experienced pain or hurting in the last 5 days? Staff may present questions or options or have them write it down, use a cue card, because you want to get kind of an idea of kind of where they're at with that pain. If the resident gives a related response but does not use the scale, you can also clarify with echoing what we were talking about earlier. Well, you said it was some of the worst pain you've ever felt. So do you think it's more here, around this 9 or 10? Or would it be around 2 or 3? That's kind of idea behind that. Now, if a resident has difficulty selecting between 2 levels, you're going to have to go with the more frequent level. Okay? And again, how's that old saying go? If you always worst case scenario, I guess. You're only as strong as your weakest link. So if it's low, I don't know. No, it's sometimes high. You got to go with high. That's just what you have to go with. So you always go with the higher of the ones because that's probably a little more accurate, and that's the one you're worried about the most, honestly. So the coding instructions are pretty easy. Number 1, almost constantly. Number 2, frequently. 3, occasionally. 4, rarely. And then 9 with the nonsensical answers that make no sense. All right? And we have a link up there now if you want to get these cue cards because they're coming up so much. Now, ask the resident each of the 2 questions exactly how they're written. There's only a few things that say exactly, and this is one of them. So, you need to be sure. If the resident's response did not lead to a clear yes or no, you got to repeat the question to the resident and have them respond to kind of narrow down their answer. Because if they're leaning one way or the other, ask it again and say, I really need a yes or a no. This is an all in or all out. And that usually ends up being, if they're leaning that way, it ends up going to be a yes. Over the past 5 days, has pain made it hard for you to sleep at night? And the next one would be, over the past 5 days, have you been limited to your day-to-day activities because of pain? And these are yes or no questions. If they're teetering on, well, is that limit? What's limit? You kind of want them to define their own idea what limit is or make it hard. But again, echoing, kind of clarifying what they're saying, and almost by the end, you're almost telling them what they're saying. They're just not seeing it. That's always helpful for them, especially if they're having trouble with this. And usually, if they're doing that, it's kind of leaning towards or it wouldn't come up. Some people are just going to say no, 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 no. But if they're getting into this, well, I do have a hard time with this. Probe it a little bit, make sure it's legitimate, and then kind of help them out with that question. All right, so code 0 when there's no pain, 1 if there's pain in the item, or 9, again, our good old friend number 9, if you're getting a nonsensical or they're not giving a response anymore. All right, so 600, you're going to go to the intensity rating. All right, for the numeric scale, say please rate your worst pain over the last 5 days, being 0 at no pain, or a 10 at the worst pain imaginable. I would say the worst pain ever. That's how I kind of phrased it. That 0 to 10, what we talked about. Okay. For the descriptor scale, please rate that intensity over your pain, which is the worst over the last 5 days. Okay. And now these are 2 different types of scale that you want to do these, with. The coding instructions for the numeric scale are going to be the numbers, the intensity, 0 to 10. Okay, you add a 0 to 10 for that intensity level. Coding instructions for the verbal descriptor is either mild, moderate, severe, or very severe. Okay? They want, you kind of have an idea of, how you're going to do this based upon the resident's ability to answer, but you only have to do one. Okay? I would say the scale 0 to 10 is the preference, I guess, of most people. It's probably a little bit easier for people to understand. It's a little more defined. Mild and moderate, those are kind of close. But sometimes it's harder to comprehend. But you just need to do one of these, and whichever one you're more comfortable with. And they're both pretty helpful. But I would say if I had to start out with a certain one, it would be the numeric scale. I think that's one that people are more universally aware of, honestly. And some of these residents have been through this before, especially if they're in they're in pain, medication, what am I trying to say? Therapy, or have a regimen of their pain medication. They probably answer these a lot because of the rules with pain meds and making sure that they're appropriate. So they're probably going to get that scale a little bit more. So that's the one I would start with. But again, you just got to pick one, and the other one stays blank. No numbers, no dashes, no nothing. Just leave it blank. Just pick one or the other. All right? Now, here's some examples. We kind of ran long on these time for this, so I'm going to go ahead and let you guys read your own examples. I'll let you download it. I don't want to take any more of your time with this. I think this has been pretty informative, and I know it's a lot to take, but we have some really good examples in here about a couple with the BEMS here, and kind of some real live answers we've gotten. Plus, I took some of these out of the RAI manual. Direct wording right out of that. Those are the examples they give you, and I think it's important to do that because I want to make sure that we express how they think some of these things should be coded. And there's some really good examples in here. I think I have about 3 or 4 of each to go through, and I will leave those for download on the website. You can kind of pull those off and check those out at your leisure. Again, if you have any of the questions, if you weren't doing them through the chat, I'm not going to review the answers, over here, but we can go ahead and send those out to people, or the people, if you're doing the chat, you probably already got them by now. But if there's any additional ones, send them by email. We'll be sure to get them back to you. Again, this is a very important part of the payment system under PDPM. We have been assisting with the assessment interviews, way back in RUGs, but the relevance got so much more important now. I think it's one of the things that we do more, especially with the ones that generate payment. And again, if you have the ability to do competency monitoring of your staff, that is the best way to make these work. I mean, it is critical that your staff conducted these interviews, understand it per the RAI manual, not even just this. They should be going through the manual and making sure they know step by step how they're going to do it. Rehab departments have traditionally gotten little to no training in these areas, and it's essential. Continued training and oversight, competency checks, at least yearly. Any changes to these things? There's a lot of companies out there, MedPass, and there's a few others that have some worksheets that you can fill out with your MDSs that are both great for 2 reasons. You have documented proof of it with the dates and everything, and you have a tool that they can use and take in there. JMD Healthcare, obviously, has been using those and suggest those, but we're also making we have an online, you scan a QR and you actually can answer the questions on your phone while you're conducting it, even show the words on your phone. So that's been a new tool people are trying to use in this new tech age. Maybe the residents won't be, some of the residents don't like it, but the staff love it. And as soon as you're done, you transmit it and you send it to your supervisor, and they get it via email, and then they have a record of it. So all good stuff, all things that are important and all things we're going to be using. I included an example of the JMD competency check form that we use. I didn't include all the pages. I think I just did the first and second page, and let everybody know that this is included with our RAM services. We will do competency checks for your people in their interviews. All right? So again, any other questions, please send them through this web portal or info@jmdhealthcare.com. And if you have any other needs, if you want to any other questions, feel free to contact us at pdpmpro.com. And I'm going to thank you for your time, and hopefully this was helpful. If you do have any other suggestions for things that may help you in the future, feel free to contact us. Again, appreciate the time. I love doing these. I love the instructions, and I hope everyone has a great day. Take care.